And how many are familiar with insulin pumps? H1. So this will be fun and interactive. I'll get someone taking notes, and so we'll just kind of go through the steps. Okay, so our objectives today to define continuous subcutaneous insulin infusion. We're not have to go into too much detail with this group. We'll talk about any myths and rumors, and so I can add to my list. Every time I hear Dr. Kilpatrick talk about the things that make diabetes do strange things, I think that list gets longer. We'll talk about indications and candidates for insulin pump therapy. We'll talk about the settings. We'll talk about the progression to the hybrid closed-loop system. We'll talk about benefits, risks, what are the available closed-loop systems, and then other devices. So what is insulin pump therapy? When someone comes to me and they said, they told me that someone had referred them to me because they want to ask about what this is. I tell them it's an alternative to insulin injections. Sometimes they come and they think that they are bad diabetics. They feel shame that they have to resort to insulin pump therapy. Barrera has a subcutaneous cannula that is connected to a device that delivers insulin in a continuous manner. So sub-Q insulin drip is sort of the simple way that we describe this enough. At a small loader that is powered by a battery, so the battery is either rechargeable, it can be replaceable, or it can be disposable, and it can be not powered, it delivers by a spring. We have control programmable parameters, so we have consistent infusion, so those are the basal rates, and you can have adjustable boluses based on meals or blood sugars. You can utilize stand-a-month, so the pump itself for communicating with the continuous glucose monitor. The cannula can be connected directly to the pump or to the tubing, which is connected to the pump. And the dosing usually occurs with direct manipulation of the insulin pump or with the remote device. Let's go through some true or false. These are fun. It's implanted. It needs a surgical procedure. Sure. False. False. Very good. But do people come? They come and feel they think I'm going to put something in their body when they come in my consult. It runs itself. There's no need to interact with it. False. Right? We need somebody to work the buttons. You do not need to check blood sugars. Okay. False. Yes, they're getting better. It's not covered by insurance. False. Getting good. Only patients with type 1 diabetes. Wow. But the president, if only agree allocations. It's obvious when you're wearing it. Let's go for it's a punishment. So these are all the things that occur at the clinic. It's a reward. It reduces hypoglycemia. Yes. It's hard to learn to use. Dangerous. And the right has. If the last resort is only for poorly controlled patients. What have you heard? Anybody else? I heard on TikTok. Just today while I was at Smiting Health Care BC. Any other myths or rumors? We got someone making notes. No, we got her off. You got to cure off. Well, cure off. It makes everything.
You just put it on, it's perfect.
That's your job. Yeah. All right. So indications for pump therapy. So anyone who needs flexibility, anybody who'd like to have less injections, anybody who needs less hyperglycemia, anyone who needs less hypoglycemia, anyone who needs to fine-tune doses in itty-bitty increments. We can set the targets for the patient and their comorbidities and their activities as well. Very flexible. Any other indications? All right, who is a candidate? So someone who's motivated to take care of their diabetes. These patients need to be aware of meal times and be willing to interact with the device at their mealtime. They need to be able to insert the infusion sets and the continuous glucose monitors. They're going to use them together. They need to be able to troubleshoot the alarms or attend to those if there's errors. And then they have to have a backup plan. And I throw that in there because I was on call for another NEC group, and over some long weekend, 7 people's pump crashed, and they had no idea what their backup was. And so I had no access to their charts, and so I had to start with, skew away. Any other candidates? Here's someone who needs rapid control of their diabetes, okay? Insulin by the wound, someone who had a surgery, but we need to really kind of get hip started and hit their blood sugars in better shape. Setting some insulin pump, so basal, that's what drips into the body subcutaneously, continuously. So I had to look at people's downloads, and I had someone who was wake up that her blood sugars were 400. And I could see that the pump is running all night long. And finally I said, do you take this off at night? And he said, yeah. I'm like, oh, you're not supposed to. No. You enter the meal bolus and the carb ratio. So those are programmed in there. So you enter your carbs and you'll do calculations. So I do tell patients this does math for you. You enter the crush or sensitivity factor. You can put in a target or a corrective of target. So those are different things. We'll get into those later. You've got an insulin action time or an insulin on forward time. So those are all the words that are used when you're programming 6. So we'll cover basal rate. So this is all rapid-acting insulin that is filled in these insulin pumps. They should not be using long-acting, please ask. Sometimes they don't get the message that it goes to stash. If you ever look at my notes or if sending you consoles aren't sending you notes back, they'll have a dose of long-acting insulin in their chart. Is just so that if they call their pump in, or my staff rush goes to tell them to take that or umper. You can set these basals higher or lower depending on their glucose patterns or their activity. So I have a gentleman who works at one of the grocery stores, and during the day, because he was so active, his basal rate was very, very low. And over the weekends, when he was home, because he was a couch potato, he had very high basal rates because he needed a lot of insulin on the weekend. You can set temporary basals for any duration of time as you need to. So work, activity, dialysis, illness. I just had a phone call today. They got just in steroids, their blood sugars were high. I said, can you please increase your basal rates to 150% for 12 hours? And they call me back tomorrow. Insulin curve ratio, we can set those to the same or different ratios with Nielsen snacks. You can individualize them at the time of the day. Patient enters their cards and into the pump and calculate their dose. So here's a quick calculation about someone with insulin carb ratio of 1 to 10. They're going to eat 3 slices of pizza. It's 100 grams of carbs, and they get a 10-unit bolus. We tell them to use nutrition labels, the internet, and an app to look up carb contents. And so if you ask your phone, you know, the person that talks to you on your phone, or the Alexa, they will tell you how many carbs are in strawberries. Settings, sensitivity, correction factors, latency on that. The math is set for you as well to my patients. So again, the patient lists their blood sugar and enters that with the pump. If the pump is the blood sugar is above target, it will take that into account, do a calculation, give them more if they need to. The adjuncts sometimes have concept that, and as students, we have to sort of go over this over and over again. I go over this with patients because they'll look at their pump and they'll say, it says I have 5 units on board, but the pump's not doing anything. And so I explained to them that according to this, the way these are programmed, it thinks that there's that much insulin in their body that is doing work. So if the blood sugar is high, they're not going to be prompted to give another dose, okay? Because there's insulin in their body, they should be doing something. It has nothing to do with acquiring for kinetics in the body. They are your own, okay? But for us, it helps keep them from stacking boluses, so they're not giving repeated boluses. Angry bolusing is what the term is, or micromanaging, or microbolusing, or microdosing. But angry rate bolusing, you gotta work that out. They're useful in not allowing these stacked boluses. You could change the insulin up or down, so you could or aggressive or more frequent controls, they can be adjusted. So these are also taken into account the hybrid closed loop. So we'll talk about this later. This is a slide that is in every single home lecture. So this is what the first prototype was, a big backpack in 1963. And then the first wearable infusion pump on the bottom in 1973. And so you see a little syringe that's filled with insulin. It's got a cannula, local dials will tell it to either bolus or change the phase. The first progression of automation was where you had the sensor augmented pump. And so the pump really didn't augment anything. The data was just on the pump. So the person that was using it was the one that would look at it and say, oh my gosh, I need to make some changes, or it would be a prompt to do something different. So they just put this data on the pump. So without any kind of automation, just having the data showed that there was a reduction in A1C of 0.8% compared to just multiple daily injections. So in this trial, they had kids that were more likely to reach their glycemic targets than those using MDI, using this pump that just had the data on it. So it's like when you put a sensor on somebody and they come in, their A1C's 14, and they come back a couple weeks later and their sensor looks amazing, and you say, what did you do different? How did you taste your doses? They say, well, I can see my numbers now. Okay, so this improves that. The next thing for automation was the suspendo low, or before low, or the predicted low. So it's the Medtronic 530G, October 2013, so we're 11 years later. It would suspend, so it would stop when it sensed that blood sugar was too low or whatever threshold that was appropriate. So there was a 40 to 50% reduction in hypoglycemia without an increase in A+C. Okay, so I think that's pretty successful. The Tronic 670G was next, so their algorithm and their technology improved. So spring 2017, they had a suspend before low feature, and the basal IQ T-Slim, working with the Dexcom August 2018, he will suspend delivery. The low was predicted, so it was 30 minutes before the hypoglycemia was expected to occur. So 50 to 80% reduction in overnight hypoglycemia without the risk of ketosis. So I think if you ask a parent or a loved one what a 50 to 80% improvement in your sleep at night would eat to them, they'd probably be beyond. 31 to 51% reduction in hypoglycemia when using the predictable glucose suspend versus the sensor augmented. So remember, sensor augmented, the patient used a loaf at the dia, and as with the sensor, the low glucose suspend, it would stop it itself. So no increase in mean glucose for hyperglycemia. So you're successfully mitigating hypoglycemia without contributing to a worsening hyperglycemia. What happens when someone has a bad low? They eat and they eat and they eat and then they rebound. So this is stuff we got. Benefits of insulin pump therapy. So if you're episodes of hypoglycemia overnight and during the day, not eating extra carbs. So if you've got someone who is trying to lose weight or cut back what they're eating, you're not having to treat as much hypoglycemia. Better A1C levels, less variability, and able to adjust those targets, whether comorbidity and corporate. Risks of insulin pump therapies, of course, errors with the motor, not charging. How many people walked out and forgot to charge their phone? Okay, so this happens. Loss of the infusion site, lack of monitoring results in no insulin delivery. So it falls out in the middle of the night. They're not listening to their alarm, so they don't wake up in the middle of your very high. They wake up in ketoacidosis. Not having a backup pump or supplies or plan or supplies, errors with doping or entry. So I've seen people, when I look at their reports, and I'll say, why did you eat 300 grams of carbs? I thought you were on a low carb diet. They'll say, oh, I said like my blood sugar to the carb, never. Or I'll say, well, why are you 60 all day long? And I'll say, oh, that must be carbs. So I'm like, hey, gosh, you're not low. And entering helpers, so someone who's not sure how to help them with that if they're not able to, and then CGM errors, so the CGMs do fail once in a while, so you want to make sure people have their supplies for testing if they need to. So the hybrid closed loop, I explained to my patients, this is sort of like cruise control, okay? So you set a speed, let's use cruise control of their car, right? Okay? Who's got a fancy camera in the front of their car that can help you augment your cruise control, right? Can we have that too? So I can program how fast my car wants to go, and I can program how many turn lakes I want to be, close or far away. Do you have Subaru? I have a Honda. Honda, that's Subaru. They can program this. So if I get too close to somebody's car, I can feel the pedal release, and so it's giving less gas, okay? And as the car moves away, if I change lane, it presses down on the pedal and gives it more gas. If the car in front of me is coming at me too fast, it'll actually put on the brakes. This is not right. So it's not one of those Ubers in Chicago that's a robot. What's next? It also tells me if I'm working out my lane obesity or if I'm going to rear end somebody, which has saved me too many times I'm not here to share. So that's my analysis when I get to talk to people about insulin pumps and what these are able to do. The Medtronic 670G has a manual mode and an automated mode. They had adjustments every 5 minutes based on their sensor data, so adjusting the basal rate. 780G is the newest version with the smart card and the G4 sensor. Just saw a press release that they approved their newest sensor, the Simplera. For all those who are Medtronic users, the sensor is flat, okay, and it's not so hard to fill out. Tandem had the basal IQ, that was adjusting the basal rates, and then control IQ, which is also coalescing. The Medtronic 780G is also coalescing as well. The Omnipod with their hybrid closed loop, early 2022, that was approved. iLet Biotics May 2023. That one's an interesting one. You can use that one for. So also, I've got a few patients who have a GIY sensor that they don't have on their phone, and then they have a little connector that connects the pump and the sensor to the pump. So it makes the hybrid closed loop different. So I think one of the biggest things to take home is that when you have patients that are making adjustments, you want to make sure they're making safe adjustments, okay? I did have a patient, she was pregnant, she had a hybrid closed loop for her pregnancy, she felt that was safer, and she was having lots of lows at night, And someone thought they'd be helpful and they would turn off her basals at night. So fortunately, she stayed in hybrid closed loop because had she slipped out of it or not put a sensor on, she would not have insulin for about 8 hours. So when I identified the problem that she was rage bolusing for this huge dinner that she was eating, she just had all this insulin floating around that was causing backflow. So as we fixed her dinner, we were able to fix her headaches. You want to be careful as you adjust, and that's responsible to the prescriber to make sure they are safe. So just like that patient if they turned to pump off, had she had failed sensor, where she would have been in trouble. So we're going to go through the hybrid closed loop pumps really quick. The Medtronic SEPT AEG works only with the Medtronic sensor. You're able to adjust the carb ratio and the insulin on board type. And you can change the target. So the target is the lowest is 100 throughout the day at 110, 120. This is the lowest one that has both the basal and the bolus feature. You can have the activity mode target that sets it to 150, so it's stopping sooner if you've got someone more active to avoid having so much insulin. Optimized settings for them, insulin on board 2 hours, target of 100. Their reservoir size is 300 units. 6-day sensor 57. Infusion set's 2, and I know they have 7-day sensor where the infusion set as well. Sensitivity is based on the previous 6 days of the insulin used by the algorithm. So every time I look at it and I'll say, I can't tell what your correction is. I think it's too much. I can't fix it. Yeah, it's based on the algorithm. So that drives me crazy when I ask them, how do I know what it's giving? And they say it's the algorithm. Dynamics 2, Mobi pump. Okay, these both have the control IQ that they're using. Connects to the Dexcom G6, G7, Libre 2 Plus, and the Libre 3 Plus. I think that's going to be connected to. The Tandem X2 has a 300 unit reservoir. The Mobi, the little one, has a 200 unit reservoir. The X2 has a screen on it, the Mobi no screen. The activity mode also did be set to 150. This one has multiple profiles that you can set, so to individualize that therapy if they need to. So I got a guy who's bodybuilder, and so he's got a very low settings when he's in his, forgot what the word is, cutting phase. And then he's got a different profile. I think he calls it like couch potato or, fat or something like that. It's just not nice. It is at very different settings for those two times of his life. Sleek target is 100, so you can program it for a sleek mode. So this just adjusts the basals only, no correction boluses. Their insulin on board time is always 5 hours. You cannot manipulate that in the hybrid pursuit. So your rage boluser sometimes don't like that because they want the pump to give them more insulin, so they'll start putting in hertz if they're not really eating. And you're able to adjust the carb ratio, the insulin sensitivity factor of this one. So if they're getting repeat correction boluses, it does calculate them based on that what you put in there, whether you'll typical dose. You can adjust those and get them to have repeat, instead of a repeated calculation, you get that to begin with. On this one, you enter the total daily dose and the patient weight, and so that they'll take into account in the algorithm. It allows the iPhone to be used as the remote or the controller. Omnipod 5, G6, G7, I just integrate this all in once. This talks to the Dexcom G6 or the G7. You can adjust your target and your correct above target. So these are interesting just because you have to favorite numbers that you've embedded. So sometimes if I have someone that programs their own, I'll look at it and I'll say, well, your target's set at 110, that's great, but your fragment target is set at 200. So this thing might sense that you get to 201 before trying to fix you. We need to make those numbers closer together. You can adjust the carb ratio, you can adjust the sensitivity, you can adjust the insulin on board, and you can also set multiple profiles. The activity mode target, 150, and the reservoir size is 200 units. So that's important when you're writing prescriptions. You need to know how much insulin you're using and sort of tell your patient how often you're going to have to change that out so they can decide which one is right for them. 100 pen is their lowest target. They have a PDM that's a remote and currently an app for the Android phones, and they're supposed to get an Apple phone in the next 2 weeks. And the Navy Libre sensor, Libre 2 Plus, okay. 2 Plus, okay. The most recent one is the iLet from the Data Bionics. Okay, this one you enter the patient fees. And that's all you can do. You have a patient weight. It integrates with the Dexcom G7. This has a 180 cartridge, so if they're using one cc as a day, they're going to choose the cartridge more often. I think they have cartridges that are pre-filled with PS. This AI calculates the dose based on CTM trend and meal prompt. So if you've got someone who you're worried about carb counting, you're worried about not carb counting accurately, this thing just asks them, are you eating breakfast, lunch, dinner? And is it more, usual, or less? Those are the variables that they can control. Your micromanagers do not like this. They cannot put in 5 units because I want it, 2 units because I want it, okay? Breakfast, lunch, dinner, more, usual, less. That's it. Here you go with the patch pump. This uses rapid-acting insulin just like the other pumps. It's got a spring in there that either drips in 20, 30, or 40 units of insulin for their basal. It's got a 2-button system that delivers 2-unit boluses at a time. You've got 18 clicks. We call them clicks. So for 36 units. So their 12 daily doses, 52, 62, or 72 units with your pill. This is great for people who are on the go that forget to take their shots with them. On the go, they have to keep it on for 24 hours to get all that basal. Okay, they don't take it off at night. C-Chair, this is another device that's filled with rapid-acting insulin. It doesn't deliver any kind of basal. It's just for clicks that get 2-unit increments. It's a 4-aware, holds 200 units of rapid-acting. I think I've got a guy who likes the Evo on, so he does need amino and a C-Cure. So that he's he needs GLP-1. All systems have cloud-based and manual retrieval software, so the professional accounts, I'm sure many of you have those set up in your clinics. Your patients should have a personal account that can also be used to share data. So again, great for telehealth. Right during the pandemic, I have a patient that emails me her records every week. Opportunities for remote monitoring. So if your client does participate in the remote monitoring, the RIP data monitoring, I got a person that does that, and I will tell her, I saw Miss Duke such and such today. I scored him on some, some Lutide. You need to see he's starting the 0.25, so he's going to take that for 4 weeks. And she's pulling blood sugars every week and looking at that we happen to do it. But she's looking at that every week and looking at how much insulin he's using and looking at how many lows he's having and let me know that I need to make a quick adjustment. We can do that with new visits. And then she'll know that he's going to go to the 0.5 milligram dose, and she'll do the same thing. Again, learn practice your regurgitation of the data if you're going to make adjustments. So anytime I make an adjustment or I say that I am adjusting the basal, it is because I'm trying to make them match what their auto mode settings are. Okay, so if they flip out of auto mode or don't have a sensor, their backup programming is similar to what they're using in the high glucose. So that's the only time you change basals. I kind of giggle when someone comes in and has turned up my basal overnight that they were too high. I'll say, okay, but I'll want you that I'll say, these are 2 units an hour. You don't use that much. You can't do that. And so I have to turn that back down to make them safer. So there's those considerations that I always have to have a backup plan. Okay, they need to know how much basal insulin they would use in case of an emergency or admission to the hospital, or if they were not able to use their pump. They need to know how to dose for meals. We need to have their supplies, especially if you travel. They need to be able to troubleshoot failures, of your devices. And they need to no need for large amounts of carbohydrates for these corrections because the pump was suspended 30 minutes before, has more, and so they could try lower doses to correct it without those huge amounts of carbs to fix their blood sugar and a regut hypertension. So insulin pump therapy is safe. It's an effective alternative method of insulin delivery that allows for flexible, accurate dosing. They've successfully shown that they improve glycemic control, so A1Cs, reducing variability, so that tight in range for those ups and downs, and keeping blood sugars in target more often, mitigating hyperglycemia and hypoglycemia. And there are a variety of systems to meet your patient's needs and their comorbidities. You need to be aware of the limitations of the adjustments and then what settings are most appropriate for your patient. You can adjust the manual settings to reflect the ivory closed loop, and this is available for many patients. I think I just got the news that the Omnipod is approved for type 2. So that should come on formularies that we've been frustrated by, then that should increase. So the future, I think the future of this would be a little more AI, so integration with other apps, so with your exercise apps. So if you're training for a marathon and you're using the Nike Run app, maybe it will learn to, sort of predict based on your past runs, if you're getting 5 miles in, that's when your blood sugar normally drops. It's going to stop mile 4. It's going to remind you that's net. GPS, so it knows where you're going. Okay, if you pull up to Chick-fil-A or somewhere else, it might remind you, I didn't see the new bowls yet. health trackers. So with the menstrual cycles, I do have some ladies right now that are sort of just watching what their requirements are. So they get their calendar and they look at the 24-hour totals. Or just plotting those on the calendars just to see if we can predict, how much more insulin we're using, when are they using it, when did that start. And then medications, steady steroids. I don't know if you want to track your Wallings app with what you're feeling. We can get a Vedral Ghost pack. I don't know if I have time for questions, but I'm happy to take any if you have me. I thank you for your attention.
One question. Okay. So what do you do in your patients with type 1 diabetes on one of these automated devices who is pregnant?
I believe, yes. So we have a discussion. We say it is, even though the targets are a little bit higher than what is recommended, what is safest for you? Okay. If the literature, they're well controlled, and some people say it's safer for me not to have lows. Okay. And then they kind of remember OBs. The OB says the babies get kind of big. When you tire control, then we take them out of the hybrid closely. Yeah. But then it's just a special, but everybody. Yeah.